For part two, I'm going to talk a little bit more about the rescue therapies of mechanical ventilation and the rescue therapies of dealing with ventilator-induced injury or severe hypoxemia. But I want to start out with this ventilator-induced injury because I think that's very important. We know ventilators are very supportive, but we also know that they can be problematic if not used right. We can get barotrauma associated with high airway pressures. We can get volume trauma associated with high volumes. And we can get what's known as repetitive alveolar collapse and expansion called RACE, or some individuals, clinicians call it shear trauma, or we can get biotrauma, meaning that if we injure the lung will release cytokines, which will release inflammatory mediators throughout the whole body and cause a surge response and cause a major global sepsis. If you think of this repetitive alveolar collapse, you think of this more in terms of like a rubber band, where you stretch, collapse, and eventually it rips and tears. Now, we talk about this because I know you picked up some patients that have been prime candidates for ventilator-induced injury. You've transferred some patients down, or you've gone to pick up some of the patients that are on high volumes, liters of tidal volumes. Think in terms of this. Most males should not be on a tidal volume greater than 700, and most females should not be on a tidal volume greater than 500, unless they're extremely tall. Remember, height is what determines lung size, not weight. As adipose tissue increases, lung parenchyma does not, okay? But as someone grows, their lungs become bigger. So keep that in mind, and you've also had patients that have been on no PEEP or minimal PEEP. I would think that at least most of the patients you're transferring should be on at least 5 to 8 of PEEP. Males 8 of PEEP, females 5 to 6 of PEEP. And the larger they are, the more PEEP they're going to need to overcome the thoracic abdominal impedance of their chest wall or abdominal wall. Okay, so those are kind of just something to think about, is that again, we try to keep the pressures less than 30, the tidal volumes less than 10 cc's per kilo, ideally 8 cc's per kilo if we can, and we have some people on board. So again, you're picking somebody up on a tidal volume of 1,000. Who are they? LeBron James or somebody like that, tall, because really they need to be tall in order to have large tidal volumes. So Dreyfus here showed real nice, and I think this is a classic slide of the late 1980s when ventilator-induced was becoming well known, that you can take normal healthy lung, as Dreyfus did here, with the normal rat lung, and then he used high pressures, high volumes with no PEEP. So you go ahead and put somebody on 1,000 tidal volume, you don't have any PEEP, and within 20 minutes you get the hemorrhagic lung. Okay, remember the X-ray I showed you early on in section 1 about the lady with the pneumonia? Look what you get. So I always tell the residents this, and they always look at me with somewhat funny, but I say to them, I can guarantee you within 20 minutes I could give everybody in this room ventilator-induced injury if you use the ventilator incorrectly. And unfortunately, you guys pick up a lot of patients that are on incorrect ventilator settings. So Dreyfus shows rather quickly, you large volumes, high pressures with no PEEP, so you cause ventilator-induced injury by barotrauma, volume trauma, shear trauma, and this is what you get. You get a hemorrhagic lung in as short as 20 minutes. And here's an example of an air leak in a lung, a pneumocoel. So there you have now the pressure has caused a rip in the lung tissue. Now what we use, and again, I you don't have this availability on some of the transport ventilators, but we use what's known as a PV tool. And as I've talked to some of you, and I talked to recently one of the guys from Medevac here, is that it doesn't really make a difference what ventilatory strategy you're using, but if you ventilate above the lower inflection point, means that you have enough PEEP, and you keep your PIP or tidal volume below the overdistension, what you do is you have optimal alveolar ventilation, or a sweet spot. So you could achieve this with a handbag resuscitator. You could achieve this with a $500 ventilator, to be very honest with you, if you could know what those numbers are. Knowing those numbers can be difficult. That's why we say try to keep your PIP less than 30, 35 here. Your plateau pressure is less than 35. Keep your PEEP enough to seal it, and keep your tidal volume in this range here. But this sweet spot of ventilation is what we always try to achieve. On our bigger ventilators, our G5 ventilators, we can actually do the PV tool. One of the guys just saw me recently do one. This is what we do to try to determine where should we set this PEEP, where should we not set the PEEP. Again, I alluded to this earlier that often acute lung injury, ARDS, is considered to be a dependent hemorrhagic injury. And you can see that the lower part of the lung here is all hemorrhagic. This person was a heavy smoker and marked by all this carbonous material in the lungs, but you can see the injury is almost, you can almost see a dividing line here. So again, this is where a lot of the ventilation goes, but unfortunately this is bloody consolidated alveoli. This is a very wet lung. This is a gunshot wound we got in, multiple gunshot wounds. They gave a massive amount of fluid, and the lung became all hemorrhagic and wet. You can't really reel the scale here, but lungs don't usually weigh 8 pounds. So you throw lungs in a vat, they usually float to the top. These lungs sink right to the bottom. But again, when you're giving lots of fluid to a patient, it's important that you're going to have to change your ventilator settings, because they're going to need more PEEP, they're going to need more pressure to stent the alveoli as you're, to try to prevent them from being flooded out. And again, this is another patient that unfortunately passed away, and you can see they have lots of secretions in the airways, which caused ineffective ventilation, and the alveoli have actually become, hemorrhagic and died. This is what your x-rays look like in patients that have acute lung injury, ARDS. Usually you have bilateral infiltrates. This is a beautiful slide to show you why just giving oxygen during ARDS isn't going to be helpful, or the patient can't breathe spontaneously. Here's a normal pain alveoli. Okay, gas comes in, has no barriers to diffusion, goes across a very thin membrane, a very minimal area of the alveolar capillary membrane. It's not wide, and it goes on to the hemoglobin, goes happily back to the tissue. Here in lung injured alveoli, you have a fluid meniscus. You have all kind of mediators or debris in there. You have a thickened alveoli, alveolar wall, and you have a widened alveolar capillary space. So oxygen tries to get in, cannot get in because it brings all this fluid and stuff. That's why you got to get PEEP to force it through, or positive pressure. And even when you get to this point, you have this thickened membrane which impairs diffusion, and then there's so much fluid here it can't get onto the capillary, and now deoxygenated blood gets to the tissue. This is healthy lungish tissue. You notice here the alveoli are all equal. There's no blood in the alveoli. This is in an animal model from Gary Neiman's group. Okay, and here in the injured lung, you're going to see a lot of the alveoli are flooded out, and some of the alveoli, like here, are over-distended, okay? Again, air will follow a path of least resistance, so you use high pressures, high volumes in ARDS. A lung like this will become over-distended and now injured, and then a sick lung remains sick, so it's ineffective ventilation. So these are all the different type of ventilatory strategies we look at with acute lung injury. We use the ARDSnet low volume ventilatory protocol, high frequency percussive ventilation, airway pressure release, ECMO, prone position, and some inhaled pulmonary vasodilators. And I talk about this because now again you probably won't use this, and you're transporting patients in for this. This might be something to try, I don't know. This would be a very good option, and obviously this is good options too. So we'll talk a little bit about these in more detail. Up until about 2010, with ARDS management, there has been nothing that has improved outcomes except lung protective ventilation. Only lung protective ventilation has improved outcomes, and we have tried tremendous amount of different things. There's nitric oxide, partial ventilation with perflubron, prone. These are innovations. We tried. There's ECMO around here. There's all the kind of thing. There's IVOX, where you actually put a oxygenation membrane in the vena cava and suck oxygen in and CO2 out. jet ventilation, oscillatory ventilation, and only study that has shown an improvable outcome has been lung protective. That's why we try to do lung protective ventilation. The lung protection ventilation, ARDSnet, is based on the ARDSnet clinical trials. There was a reduction from 38% to 22% in the lung protected group versus the injured group. We're going to use a low tidal volume, low plateau pressures, and this is extremely important, and a lot of clinicians still struggle with this. The goal is not to reinflate the sick units, but to protect the healthy lung units. Remember, there's 300 million alveoli, so if we can protect the alveoli that are still healthy, the patient can go on and do fairly well. And over a period of time, they'll get better. It's marked by maintaining a saturation above 88%. Not necessarily 100% sat, not necessarily 95%. The goal is to give adequate oxygenation, not optimize oxygenation. And usually the x-ray doesn't really change because we're not really trying to go after the sick lung units, and you maintain that for a few weeks. So that's kind of hard for clinicians to understand that, because everybody wants to see pretty blood gases and nice clear x-rays, but that's not really the goal of ARDSnet. Here's the ARDSnet protocol. You can see there's an oxygenation goal is between 55 and 80. It's almost the same as when we have on BB ECMO, and the main sat's 88 to 95%. There's no hundreds there, okay? And what the ARDSnet simply does, it tells you, look, if you're on 80% and 14 a PEEP and your oxygenation's goal is okay, you're reaching your oxygenation goal, drop to 70%. Then if it's still good, drop the PEEP, drop the PEEP, drop the PEEP, okay, and then that file too here. So the idea about ARDSnet is that you're trying to maintain a low tidal volume. You start at 8 cc's per kilo of predicted body weight, you adjust it down to 6 cc's per kilo, and at the same time you adjust your F file to PEEP algorithm. This is a lung protective strategy. This is what I'm trying to get a place like Hazleton to initiate. They have a patient who's sick. Put them on lung protection. Keep the plateau low, keep the tidal volume low, and use your F file 2 and PEEP judiciously. The reason this was developed was not for institutions like ours. It was developed for institutions like a place like some of our neighboring hospitals, where they don't have a lot of clinical resources or a lot of clinical experiences. This is a nice, for lack of a better word, a cookie book, cookie cutter recipe, cookbook recipe that allows the clinician to ventilate patients, again, adequately and ideally. And there's weaning ways of doing it and stuff on how to wean patients and things like that. And again, this is interesting too, because you don't wean them on CMV. Once they're stable, you go ahead and put them on pressure support. See, pressure support weaning. So even though they're on a rate of 30 on CMV, you don't have to turn the rate down to 25, 20, etc. You just, if they're stable, take them off and have them start breathing spontaneously. And then you do the unassisted breathing trial, or the SBT trial that we talked about earlier. Now, the next kind of therapy I like to talk about is airway pressure release therapy. This is extremely good in patients that have morbid obese. I'm talking about BMIs greater than 40, maybe greater than 35, 40, 45, large individuals. Or they have lots of fluid on board. It's marked by having you're up 10, 15, 20 liters of fluid, okay? The idea with APRV, there's two levels of CPAP. There's a P high and P low. There's a release volume, and you're using time along with pressure. So you put a pressure patient on a pressure of 30, and you give them 5 seconds of inspiratory time. So you're using sister and daughter alveoli to help inflate the sick alveoli. And here you can see I have a pressure of 22 in. We're going to hold in for 4.6 seconds, and we're going to let it out for 0.7 down to 0. It never goes down to 0, as you can see in this picture here. This is all inspiratory time, expiratory time, so this is recruiting alveoli, oxygenating alveoli, and this is we get rid of CO2 elimination. Okay, and volumes released are pretty high, and some clinicians are concerned about that because it's way above 10 cc's per kilo. But remember, it's a release volume. It's not gas going in, gas going out, and it reflects over a long period of time, so the volume is going to be higher. So it is considered to be a lung protective strategy, even though the volumes are high. This is on G5. Again, here's a patient on 30/0. Their eye time here looks like it's 1, 2, 4, almost 5 some seconds, and there's a release volume there. All right. So again, you can see we have the lungs really optimized and inflated fairly well. So APRV, again, the classic patient is patients that are going to be weight fluid overloaded, they're grossly fluid overloaded, and or patients that have morbid obesity. High frequency percussive ventilation is a pneumatically driven ventilator. You need no electricity with this ventilator. It is purely pneumatic. It sucks a lot of air, gas, but it's pneumatically driven. Pressure limit, you set a pressure. Time cycle, you set a rate. As a high flow interrupter, and it can deliver high frequency breaths, somewhere between 200 and 900. Usually we use between 400 to 600 in our practice. And exhalation is passive, which is different than an oscillator that they use up in the NICU, where exhalation is actually active, meaning that a diaphragm pushes air in and a diaphragm sucks out air also. So diaphragm oxygenates, diaphragm gets rid of CO2. The VDR does not do that. Here's again, you have two rates. There's your regular pressure control rate, like a PCMV rate, for lack of a better word. Okay, there is your pulse frequency. So here you're getting percussive rate on exhalation, and then you have percussive rate on inspiration here. Picture of the VDR for those that haven't seen it. It's usually the way the nurse acts when I usually bring that into the patient's room. Now, the tidal volume you can't measure on this device. It's a combination of all these different, just like in pressure control, you can't deliver, measure an exhale tidal volume or set up to exhale tidal volume. On this device, you can't either, but you can actually even measure the exhale tidal volume. It's going to be a measurement of basically what your PIP is, your PEEP, just like in dual PAP pressure control, and how much the subtidal volumes add. You have to use your assessment skills. Does the chest rise? They're being ventilated. Chest doesn't rise, they're not being ventilated. The idea is this here. The idea is the development of an endobronchial wedge. You want to use the subtidal volumes to open up the airways, get rid of the cellular debris, mucus, secretions, blood, fluid, whatever may be in there. In the burn patient population, what's the word I'm looking for is the sloughing of the airway. The airway sloughing off where the trachea or thermal burn occurred. So the idea is just like in football. If you kick off, to me, I grab the ball. What do my blockers try to do? They try to create a wedge. Well, this wedge opens up the airways so gas can go in, thus oxygenate, recruit, and CO2 can come out. Also, these subtidal volumes create what's known as an internal mucokinesis and help try to move secretions and debris out of the airway so that it can be suctioned more readily. Okay. And on this device, again, it's not that easy to set things, but typically you can where the needle goes up, that's your PIP. So here's a PIP of 36. Where it comes down is your PEEP. That's a PEEP of 18, and then here's your mean airway pressure would be in the middle 20s. So it's quite easy to kind of read once you get familiar with it. This is alveoli, what you want alveoli to look like during high frequency percussive ventilation. You can see everything's equally inflated. There's no debris in the lungs. Now, it can be used in all kind of patient population. I can't really show you this video in this setting, but you can see it can be used in the neonate population, the pediatric population, and also in the adult population. Now, when we talk about the next, we talk about these inhaled pulmonary vasodilators. Here's an indication, primary and secondary pulmonary hypertension. So we do use this in the open heart unit. We do use this in other places in the ICUs for patients that have increased evidence of pulmonary hypertension, because again, by dilating the pulmonary basal bed, you will decrease the pulmonary pressures. We use it in the open heart unit and actually doing cardiac surgery for patients that have pulmonary hypertension or right ventricular failure. Lung transplants we don't do here, or liver transplants, but it is used in those patient populations, and obviously we use a lot hypoxia due to single lung ventilation or ARDS. So really we use, I'd say this would be 20%, 10%, this would be 70%. And again, this talks about lung inflation, inflammation, and a lot of information in how pulmonary artery pressures and pulmonary hypertension lead to a negative sequelae. So if you have an increase in pulmonary vascular resistance, you'll get pulmonary hypertension, which will increase pulmonary edema, increase hypoxemia, which then you have to increase the amount of oxygen, which causes more problems. So this is a nice sequential type of algorithm that shows you the different type of factors that occur when you have increase in pulmonary vascular resistance or pulmonary vascular obstruction. It increases blood flow to pulmonary vascular beds. It can decrease pulmonary vascular resistance or pulmonary artery pressure, and it can improve arterial oxygenation and thus improve ventilation mismatch. So again, what I kind of alluded to earlier, that I'm going to take blood from closed alveoli, which is deoxygenated blood, and shunt it over to open alveoli and thus increase the amount of oxygenated blood. And this is better than using systemic vasodilators like nipride and those type of drugs that also cause vasodilatation, because one of the problems is it dilatates all alveoli. So if you give a systemic vasodilator, you may worsen the PO2 because you increase blood flow to even closed alveoli, where inhaled pulmonary vasodilators only ventilate or only go to the open alveoli because it comes in through the alveoli. So if the alveoli is closed, you're not going to get any of this agent, only open alveoli, which means it increases blood to only those alveoli that are patent or healthy, which decreases shunt and then increases oxygenation. So for years they tried to improve oxygenation by doing this, but they actually made it worse by using IV drugs, systemic drugs. Now the inhaled rate, nitric is a gas and Flolan is a nebulized solution. And the evidence has been very good to show that it does improve PO2. So baseline, here is your PF ratio. This is your mean arterial pressure, mean arterial blood pressure, and mean pulmonary artery pressure. And you can see that if you give Flolan and just epostesinol, you can see that the PF ratio improves tremendously, the blood pressure increases, and the pulmonary artery pressure decreases. So that's what you'd like to see. This is the typical Flolan setup. All right, you have the pre-fixed syringe from pharmacy, usually 20 mics per 8 milliliters, 160 mics per hour, and you have the nebulizer that goes on the dry side of the humidifier, and it's quite easy to deliver. And nitric oxide, you actually set a device that gives parts per million. 20 parts per million is usually the starting dose, okay? And then if the patient has a good response, you wean that down, and that's put in line with the ventilator. This is the INOVent. So inhaled pulmonary vasodilators continue to be utilized despite little positive outcome data. What that means is that they haven't been shown to improve outcomes in the sense of mortality and morbidity, but most clinicians continue to use them because they give you time. They buy time so other interventions can be used. Nebulized options have gained popularity over gas options. For example, Flolan costs $11 an hour to administer. Nitric oxide is almost $150. Caution needs to be utilized with these drugs. I mean, Flolan can cause the exhalation valve to gunk up. Nitric can cause methemoglobin. They're not benign agents, but they've been used for years and they will continue to be used. Kinetic bed therapy, okay. In order to be effective, you have to rotate at least 40 degrees, and the idea is that you're going to change ventilation perfusion matching. No doubt about it that if you rotate very little, you get very negative effect or no effect. You can see if you do 60 degrees, so you really turn the patient, you can improve the PO2 dramatically just by positioning. And this is, again, more statistics. There's reduction in ICU, reduction in intubation, pneumonia. So kinetic bed therapy is used quite frequently. Again, improves mobilization of secretions, resolution of atelectasis, better matching of ventilation perfusion. decreases interstitial accumulation. Now, this is important. In order to be effective, you need to do this for at least 18 out of 24 hours. You can't just throw a patient in prone position or kinetic position for 2 hours and expect it's going to work. They need to be in it for quite a long period of time. Prone positioning. Let's see here. Yeah, the supine position, you know, the way the heart's on the lungs, the dorsal lungs are compressed. Remember I told you the dorsal append part is the part that fills up and the abdominal contents pressed. So there's a lot of negative consequences on a patient laying supine. You know, we do put them up 30 degrees now, but still you have some of these factors. So patients that don't oxygenate well do better when they're placed on their face. It limits the lung compliance and it causes ventilation perfusion mismatch. So again, the results, the bases are better ventilated, and the problem is that that's where the blood's going, and if the patient has a hemorrhagic lung disease, the base is going to be flooded out. So when you look at ventilation perfusion, you know, gravity makes a big difference. So when you look at proning, you see patients here with all this hemorrhage, with all this congestion in their lungs, and then after 2 days of proning, you can see that you decrease it. The idea with proning is that by proning the patients, you allows you to come down your ventilator sense, so your ventilator becomes less ventilator injurious, in the sense that you can come down your airway pressures, you can decrease your PEEP, things like that. Here's another patient, okay, that has congestion. You can see you go from enrollment to 2 days later, lungs a lot clearer because you get better ventilation perfusion in the prone positioning. And again, this is some data again showing that again group 2, which was the prone group, showed a much decreased amount of days on the ventilator compared to the group that wasn't. So this patient got 12 hours of prone, just got about 20 hours of proning, and the proning and longer proning ended up being beneficial to the patient. Here's one of the types of beds we use for proning. This is called the proning bed. This is called the rotoprone. You put the patient in, the thing spins around. ECMO, this makes great sense to me. Why do you do ECMO? Well, veno-venous ECMO is what you use for oxygenation and ventilation problems. The other group of patients you forget about a lot is patient with status asthmaticus. We've had 4 patients now on ECMO because of status asthmaticus, because we could not get rid of CO2 or oxygenate with how high injurious pressures. But most of the time, you patients on ECMO that have ARDS, and the idea is you want to rest the lung and minimize lung settings while you allow this device to oxygenate and ventilate the patient, avoiding ventilator-induced injury. As I said, a lot of times when you're looking at ventilation and patients aren't doing well, you're damned if you do, if you're damned if you don't, because you're trying to improve oxygenation, but it's at cost of high pressures, high ventilation, hemodynamics, and if you don't do anything, the patient ends up dying. So, you know, what are you going to do? It's like this cartoon here. Technical aspects, again, a cannula is put in, and you try to get the oxygenated blood out of the device, out of the body. It goes into the device. It goes to an oxygenator. The blender controls oxygenation. This is here, controls oxygenation of the blender. And then the CO2 is eliminated through this sweep here. Now, usually in ECMO, initially they're 100%, and we usually could consider 70 to 100% high FiO2, 40 to 70 moderate, less than 40 minimal. Same thing with sweep with the blender here. If you have 1 to 2 is considered to be minimal, 3 to 5 moderate. When you have to have more than 5 a sweep, that means the patient has a lot of dead space in their lungs. So again, you know, don't get me wrong, ECMO is fraught with a lot of problems, but again, it makes sense because like a lot of other type of procedures, so if I have knee surgery, they don't have me go out and sprint or go and run long. But when we have patients with lung injury, what do? We use high pressures, high oxygenation, and it doesn't make sense. So ECMO seems to make sense where if the lung is injured, let's rest the lung, let's try to oxygenate it and ventilate it by using ECMO, and keep your minimize your ventilator sends, and use your ventilator just to maintain lung mechanics or to help augment ECMO. Like for example, we will put patients that are on ECMO on the VDR, and people say, why? Well, it's not necessarily used to oxygenate the patient, but it's used to maintain the lungs open, and it also helps to mobilize secretions. Because remember, when a patient comes off of ECMO, they still have to be weaned on the ventilator, off the ventilator, and if you have forgot about the pulmonary mechanics and you allow the lungs to fill up with secretions, you're going to have a lot of difficulty weaning. These are closer. Look, we use the single catheter, double lumen catheter, the Avalon, and this is kind of the placement by the mitral valve. Mitral valve, I'm sorry. An example now with this is this is a patient that has VA ECMO, where they're actually, again, they have 2 cannulas and you're taking oxygenated blood out, deoxygenated blood out, and oxygenated blood out. They usually have a cannula in each part of their groin, femoral access. There's examples, again, this would be probably VA, and this would be V to V. Again, VA with 2 cannulas in. Here's one of our actual patients. Here's a good example of the Avalon catheter. Again, VV usually used to require for oxygenation, bypass the lung, but requires adequate left ventricular function, usually used again for respiratory problems. VA is often used for cardiac problems or for severe oxygenation problems because of ARDS. We've not had to do that. But that bypasses both lung and heart and unloads oxygenation blood into the aorta. So in VV, you're dumping it back into the ventricle, so the heart pumps it out. Here, you're really bypassing the heart and the lung. Usually this VA is used for hemodynamic sequela, patients that have retractable cardiac arrest, patients that are retractable cardiac shock, cardiogenic shock, or patients that are just, have problems in the OR and maybe blow a vessel or a valve or something like that. Or sometimes it's used as a bridge until heart transplant. Okay, we look at Murray scores. That's how we identify patients for ECMO. Right now, as I was just talking to one of my therapists between session 1 and session 2 here, we have a patient that we calculated a Murray score. It was 3.5, which is usually indicative of possibly needing ECMO. If you look at PF ratio, lung compliance, X-ray, ventilator settings, and you look at this here and you get points. So the PF ratio is, like this patient's 125, they get 3 points. Quadrants have infiltrated, they get 4 points if the whole lungs are infiltrated. They're on 10 up PEEP, so they get 2 points. So here we got 3, 4, 2, so we have a 3.0 right now, and compliance is less than 20, so that's 4. You add those numbers all up, those columns up, divide by 4, and this patient's a 3.25 that we have upstairs, and now that page says that if it's greater than 3, you think about maybe ARDS. And then they even go, when the Murray's 3 to 3.5, the mortality is 50% for those patients. When the Murray score goes from 3.5 to 4, the mortality goes up tremendously. And then, as I said earlier, don't be afraid to use ECMO for patients that have status asthmaticus, their CO2s are high, their pHs are low, and their plateau pressures are high. Or we've used it also. We had several patients that had multiple holes in their lungs, and we had to use independent lung ventilation along with ECMO in order to protect one lung. Like one lung got minimal pressures while the other lung had to get higher pressures because it had a pneumonia or some kind of other problem. So this is when we think about ECMO. So when you hear the term Murray score, that's what that means. It's an assessment criteria to figure out if a patient is a candidate for ECMO. So when you go pick up your patients, you could do a quick Murray score because they're going to be on a ventilator. You'll know what the PF ratio is. You'll know what the compliance was. You got to look at an X-ray, and gives you an idea how sick those patients are. Patients that have high Murray scores need to have quick intervention, or they have a high chance of death. And our goal, again, is to maintain lung recruitment, but do all the things we've talked about not to do with ventilators, and then provide oxygenation and ventilator. And if the VV cannula fails, if it gets blocked or the machine fails for whatever reason, we have to ventilate and then provide mucokinesis. Because remember, again, a lot of times people forget this, after they're off of ECMO and get decannulated, they still need to be liberated from the ventilator. So if you don't do good maintenance while they're on ECMO, they're going to be stuck on the ventilator for long periods of time. And these are some typical ventilator settings we use. And again, nothing that we haven't talked about today. Usually the FiO2 is always less on the ventilator than what the ECMO FiO2 is. And we use all, we use all the ventilators. We've used APRVs, things like that too. This is a patient on ECMO, and you can see you're using V, C, and V. So here again, we're on a pressure of about 28 there. PEEP's 15, PO2's 50, and the compliance is pretty poor. But we have good ventilator synchronization, and we have a tidal volume that's about 6 to 8 cc's per kilo. So in this situation, we're pretty lung protective. But the compliance is still pretty poor, but we like to keep the compliance above 20 on the ECMO patients so we can help wean them quicker when they come off. We've actually published some data showing that the way we ventilate during ECMO actually decreases one ECMO duration and then ventilation post-ECMO. And again, the VDR, we use it for maximum ECMO settings, patient retained secretions, inadequate lung inflation, poor compliance, and unilateral lung disease processes. And we know this is before and after, so these are airways in the burn patients before the VDR, and you can see there's a lot of burn and carbonous material, and you put them on the VDR for about 48 hours and it cleans up. They still have some debris in their lungs, but you can see that their carbonous material is gone. So again, in ECMO, the goal of the ventilator is to maintain lung mechanics and backup oxygenation, ventilation, and the basics of airway care and patency needs to be still employed. And spontaneous breathing, we have patients, someone asked me today, did you ever have patients breathe on ECMO? Sure we have them breathe. Because again, if we can let their there's a lot of benefits from spontaneous breathing. Less sedation required, more effective ventilation, distribution ventilation, getting that dorsal dependent part of their lung move in. So yeah, make them come more comfortable and let them control their respiratory pattern. We definitely want them on pressure support and maybe even a high pressure support, but sure, spontaneous breathing is encouraged. So concluding this section of the presentation, I just want to talk about that, acute lung injury continues to have a high mortality and rate, and it's a common disease process we see in critical care. This is a hospital that gets a lot of different patients from a lot of different other surrounding areas and hospitals, and we have a good fair amount of population in the city, and we get a fair amount of patients with acute lung injury, ARDS. I think recognizing patients at risk and instituting the proper ventilatory strategy improves the outcomes. There's no doubt about it that studies have shown that if you are proactive versus reactive, and right from the beginning you use lung protective strategies, and now ECMO has been another weapon in our arsenal, we can have good outcomes. And it's very, very important. We're not trying to get perfect ABGs, okay? When selecting a ventilatory strategy, we need to be lung protective and not necessarily get perfect ABGs, because again, making the PO2 PERD at the expense of hemodynamic or performance or the expense of the lung can, in the long run, be very detrimental. All right, so this perfect ABG only maybe exists on textbooks or on tests, but in reality, most patients don't have perfect ABGs. They don't have perfect pathophysiology. And the learning curve regarding the therapies that we do will never be static, and the more therapies will be researched. And maybe if I would have given this lecture 10 years ago, I wouldn't have had things in there about ECMO. I wouldn't have had it in there about Flowland. So, to be honest with you, over the 40 years that I've done this, the way we ventilate patients is always changing. And now with things like modes like ASV and other closed-loop ventilation modes, hey, in the near future, there may be other modes of ventilation, other ways of ventilating, where someone may turn around and say everything we're doing right now is not right, and we need to rethink the way we're providing ventilation. So, I hope this has been helpful, and, again, any questions, don't be afraid to ask myself or a respiratory therapist. We're here to help you, and, and good luck, and, we admire what you do. It's not tough going out there and getting those sick patients. All right, take care.